My name is Stephen Kennedy. I'm the head of the Nuffield Department of Women's and Reproductive Health and your co-host this afternoon. My background is that I'm trained as an obstetrician and gynecologist, and for the last 12 years I've jointly led a project around the world studying human growth and development. My fellow host is Robin Norton. Robin's an epidemiologist. She's principal director of the George Institute for Global Health and the acting director of the George Institute here in the UK. Her research focus over the last 30 years has been non-communicable diseases and injuries. We are really excited that you've elected to join us this afternoon to discuss what we think is a really innovative approach to women's health around the world. How did this all start? Well, about 3 years ago, together with others, we published an Oxford Martin School policy paper which was launched at the House of Lords, which brought together our respective interests in women's health. And it followed the George Institute joining our Department of Women's and Reproductive Health. And this document had two primary aims. We recommended that the current agenda in women's health focus so much on reproductive and sexual health, as important as it is, nevertheless should be extended to take a life course approach to women's health, because the leading causes of death amongst women and girls are not the traditional subjects that obstetrics and gynecology study. Rather, they are non-communicable diseases and injuries. And the paper also recommended that significant gains in the field of women's health will never be achieved unless we include women in clinical studies and research into subjects such as this. And not until all data are disaggregated by sex and informed by a gender perspective. Now, since that paper was published, many others around the world have been encouraging a similar approach. And many of you, I'm sure, will be familiar, and why this meeting is so incredibly timely. In fact, it couldn't have been timed any better. On Monday, the British Heart Foundation, as I'm sure you have read, published the rather sad data that in this country alone, over the last 10 years, 8,000 women are estimated to have died from heart disease because their symptoms were not recognized as typical of cardiovascular disease and because their presentation with heart attacks largely are not managed well enough, as they would have been had those women been men. And we strongly feel that the time is right for adopting a new approach to the whole issue of women's health, not just in high-income countries, but also in low to middle-income countries around the world. And we feel that by harnessing the energies and expertise of people like you, this university can make a substantial contribution to improving the lives and general health of women and girls around the world. Now, as you will be familiar from the information we've already sent you, we have three specific aims. To highlight some examples and I emphasize that, just some examples of the research that's currently being conducted in this university in the field of women's health. To discuss what we believe is the enormous potential for collaboration of a transdisciplinary nature across academic groups, not only in this university, but with others outside as well. And later on, to work with you to outline a vision for women's health at Oxford that really focuses on using science and our academic expertise to deal with the whole issue of inequalities for women and girls across the world. And we hope that when you leave at the end of this afternoon, you will be sufficiently enthused to believe that this is a worthwhile thing to do and that you want to take part. I'm now going to hand over to my co-host, who's going to say a few words and introduce the key speaker. Thank you.
Thanks everyone, and good afternoon, and a very warm welcome from me also to the symposium this afternoon. It's great to have so many people in the audience, and we do have a fantastic lineup of speakers for the day, as well as a wonderful group of attendees, ranging from senior academics to students, as well as professional staff across all divisions within the university, and with a diverse range of interests in women's health. Indeed, we have used the responses from the registration details to provide a visual representation of the range of interests of those who are attending, as shown. But to this afternoon's proceedings, the intention is that while learning from others, we will also maximise input and engagement from all of you who are present. To that end, and in addition to asking our speakers to make relatively brief presentations, to allow for audience interaction, we're proposing to use Mentimeter. Now, some of you have probably used it before and know all about it, others may not. But it's an interactive internet-based platform to solicit your questions and comments throughout the symposium, and later in the day to ask you questions and seek your responses to guide us to the next steps beyond today's meeting. So while generally at meetings like this, we ask people to put their mobile phones away, on this occasion, if you can bring out your mobile phone, or if you've got a computer with you, we would encourage you to log on to menti.com and use the code 180848, and it should come up and ask you to straight away start putting in questions or comments. And we would aim to try to respond to some of those questions and comments throughout today or later if we don't get a chance to do so. Please feel free also to use social media if you wish, unless individual speakers specifically ask that you do not, and use the hashtag #OXWoman. Do we have it there? No. Oh, no. OXWoman, O-X, capital W-O-M-E-N. We will have microphones available throughout the interactive sessions. Please do identify yourself and your affiliation, departmental affiliation, when you speak. Lastly, I would like to thank the Oxford Martin School for hosting us in these wonderful premises and for providing funds to support this event, namely the networking drinks later this evening, as well as funds provided by the George Institute's Global Women's Health Programme. I would also at this stage like to thank too the amazing team that have been working behind Stephen and I in preparation for this meeting. As you entered the building, you would have been confronted by an array of people who have been supporting it, and I really would like to make particular mention of Elisa, who's at the back, who's the Program Manager for Women's Health at the George, and she's been hassling the speakers over time to get their presentations, but she's done a fantastic job, supported by a group of volunteers. So it remains for me to say, before I introduce our keynote speaker, we hope you have a great afternoon. We hope you enjoy the symposium, and we look forward to your contributions. Thank you. So now, it is my great pleasure and indeed a privilege to introduce our opening keynote speaker, Professor Dame Valerie Beryl, a fellow Australasian who has spent most of her working life in the UK, firstly at the London School of Hygiene and Tropical Medicine, and since 1988 at the University of Oxford, when she was appointed as Director of the Cancer Epidemiology Unit. A major focus of her work has been the role of reproductive, hormonal, and infectious agents in cancer. She is the principal investigator for the Million Women Study cohort of women's health, which leads international collaborative studies of breast, ovarian, and endometrial cancer. Her current research is broadly aimed at understanding the major modifiable causes of morbidity and mortality associated with ageing in women, using the wealth of personal data collected from participants in the Million Women Study cohort, in combination with routinely collected information on disease outcomes from linked NHS medical records. While Professor Beryl continues to work on a wide range of cancers, these studies also include work on the causes of heart attack, stroke, and blood clots, osteoporosis, fracture, and dementia. Truly, the Million Women Study is a landmark study for women's health. And given today's meeting, we thought it entirely appropriate that we begin the day by recognising the huge body of work and contribution to women's health generated by Professor Beryl and her team, by inviting her to address us today. Professor Dame Valerie Beryl.
Well, thanks Robin and Stephen for your introduction, and thank you all for being here. Now, let's see if this is going to work. No, anyways, I've been asked to talk about the Million Women Study, which is probably one of the largest, if not the largest, and one of the most long-standing, if not the most long-standing study of women's health in Oxford. Now, if you can go on the next one, okay. Now, just to give you, I'll say a few words. I haven't got that much time, but I'll just say a few words about the Million Women Study. In 1996 to 2001, which is more than 20 years ago now, we recruited women into a study which we call the Million Women Study from 66 NHS breast screening units in England and Scotland. And at that time, the areas were divided. There are about 100 different regional health areas. And we selected, not all of them took part for various, often very practical reasons. They couldn't put questionnaires into envelopes and things like that. But we managed to recruit about half of the women who we sent questionnaires to, which represented about 1 in 4 of all women in the UK who were born between 1935 and 1950. The average age then, about 20 years ago, just over 20 years, was 56. Now it's 77. Now, the reason we started that, and I think the reason we had such good uptake and involvement, was we wanted to get reliable evidence, and the prime reason was on breast cancer and use of menopausal hormones. But it was really clear if we were setting up a prospective study that we'd be able to study lots of other exposures, smoking, alcohol, socioeconomic differences, all sorts of things, in women's health in general, not just in breast cancer, but different things. And we've continued to do that over the years. And you can see, you can find out all about us and what we've published on the website. But I'm just going to talk about breast cancer and menopausal hormones today. That's all I've really got time to do. But I should say that when we started this study 20 years ago, all you could get information, all the records were manual, right? And you could link, the only things you could get follow-up routinely for in the UK were cancer registrations and deaths, and everything was done manual. You had to fill out a million forms and send them to Office of National Statistics then, and they would send us back any cancer registrations or deaths that occurred in the population or immigrations. Since then, I mean, unimaginably so, the electronic, I should say that the reason we could do the study is we already could enter all the questionnaire data electronically, and we were very much in the, just as this possibility was started, so we entered all the basic questionnaire data electronically. But then, over time, it's been extraordinary, the growth of and the possibilities for data linkage. So now we've got information on hospital admissions, screening history, GP visits and prescriptions, just from it's only a subsample of the population, the CPRD it's called, that we link to, and immigrations. And so we really can, for the whole population, follow people, and now it's for over 20 years, and only just over 1% have been lost over 20 years. It's really just, we've got complete follow-up because when women were recruited, they had a unique NHS number. We've used the unique NHS number and the date of birth to link people. 200,000 have died, and we know the cause of death. We have something like, I can't remember if it's 9 or 11 million hospital admissions with cause-specific hospital admissions. Got a huge amount of data that we've used in various publications, as well as the baseline questionnaires. We send out to the participants a postal questionnaire every 3 to 5 years. I think we're on our 5th or 6th now. We're also, since 2010, started with online questionnaires at all. So we've got this massive amount of data, and we really couldn't think about it when we started the study. It's been extraordinary how data available. It's very complicated to get permissions, but once you get permissions, the data are fantastic and very reliable too. We've done a lot of validation studies. Now, why were we interested in menopausal hormone therapy, and why did the study start? And the reason was that this is data during the recruitment period. This is what happened, and this is actually worldwide, the figures, the number of of hormone users in the world. It went up from about less than 10 million in about 1990 to over 30 million by 2000. And it was this enormous increase, and the screening program was inundated by women when they went for screening, asking, what do I do about hormone replacement therapy? What should I do? And it actually slowed up the very efficient running of the screening program. So they were happy for us to just send a questionnaire to people before they came to the clinic and post it in some sort of like an electoral box before they were screened, because they, as much as anyone else, wanted to know the answer, what was the effect of hormone replacement therapy on breast cancer. So that's why that's why the screening program agreed for us to send out the questionnaire, and why we had such a good response rate from women, I think. Now, I just showed that little blip in the 1970s. I want to just draw your attention to that in a minute, because there was this idea starting about 1970s, sort of feminine forever. If you problem with the menopause as people become old and decrepit and so forth, and if you took hormones, that would, particularly estrogens, that would reverse these sort of depressing things about the menopause. And so, in California, largely, women started taking hormone, Western USA, started taking hormones in the 1970s. But very quickly, there was evidence grew that taking estrogens alone in postmenopausal women increased the risk of endometrial cancer by a large amount, by relative risks of 2 or 3, very big relative risks. And although it was disputed, use did drop, and it was finally accepted that this was really a risk of estrogen-only hormone replacement therapy. But during the 1980s, work was begun showing that the work was published showing that if you added progestogens, another hormone, to the estrogens, that would prevent the development of endometrial cancers. So a lot of the use started to increase by giving women who had a uterus progestogens as well as estrogens. And at the same time, there was all this publicity that was not very strongly evidence-based, saying that HRT may increase life expectancy, reduced heart attack risk, all sorts of things that were not evidence-based. And so that's the sort of background of why we started, because we did start doing pilot studies in about 1993. Every time we did another pilot study, you could see use going up and up and up. Initially, we didn't know that we had enough power. But at the same time as we were starting our work in the States, I mean, it was recognized by epidemiologists, I'll say, that this was really not the business about improving life expectancy and preventing heart disease was not well based. And they started a trial that many of you have heard of, the Women's Health Initiative trial. It started in 1993, just at the time we were starting. And in 2002, published these very famous results. Many of you heard the Women's Health Initiative results with estrogen plus progesterone. They didn't publish the estrogen only, I'll talk about that later, which showed that not only was there an increase in breast cancer, which I've just marked there, you can't see it, but there was also an increase, not a decrease, in heart disease, increase in venous thromboembolism, increase in stroke. And so that was very widely, it was a randomized trial, it was a very well done randomized trial. And then we published, and so just so happened that we had, because at the time when the Women's Health Initiative trial was published in 2002, there were a lot of questions in Parliament. Tony Blair said, oh yeah, but that doesn't apply to women in the UK, the different medications. And so we published it a year later, 2003, in the Lancet, showing, and if you're familiar with this forest plots, but I can tell you but they show that every type of, if people were taking, at the time when they were recruited, any of the hormones, there was an increase in breast cancer risk. But what's really important is that this was estrogen only. This was the risk of breast cancer, 30% increase. But if you added the progesterone, which was very good for the uterus, you doubled the risk of breast cancer, which is much more common than endometrial cancer, much more fatal. So we published that a year later, and I guess mainly the trial findings, but ours added to this really big drop in use of hormone therapy. In about 3 or 4 years, use halved around the world. But it still has stayed at about 12 million around the world. There's 1 million users in the UK. And over the years, because such strong evidence in the around sort of 2020 to 2002, 2003, 2004, and they were the main findings. But over the course, particularly of the last few years, there's been this sort of murmuring by people, often with commercial interests, that, oh, the trials were wrong and we were wrong, and really HRT is safe, which has said a lot, and it's mostly in the media. There's no scientific evidence. The people who say the trial and our findings are somehow wrong don't publish in the scientific literature, they just go to the press. So what we did, and I'll just finish quite soon, but what we then had to do was set up an international collaboration, not just with the Million Women study, but throughout the world, to get all the original worldwide data together in one place on every study that with more than 1,000 cases that had looked at breast cancer risk and in association with the use of hormone therapy. We ended up, and it was all the eligible studies in the world, we ended up with 100,000 women with breast cancer. There were 65 on average, half had used HRT, most had started between 50 and between 40 and 59, mostly start around the time of the menopause. But this is what we found, and these are the relative risk. This is how great the risk, the relative risk, depending on duration of use. You can't see, but this, and it's all compared to never uses. Now, use for less than a year, there was almost, and this is just the current uses, there was no increase, but this is just with 5 to 9 years, average of 7 years use, there was a doubling of risk, and it kept going up. This is 15 or more years, 20 plus, and you can see the risk are much greater for estrogen plus progestin than estrogen only. So this was really, it's sort of what we and others had published by putting together the worldwide evidence. Absolutely beautiful, clear results that are pretty hard to knock because there's so much data and such clear linear relationships. I'll just say, but it's not, probably no one here is of much interest, but there was this view that was pushed around by some people saying it's okay, the risks are only there if breast cancer, if women start in their 50s. If they start at younger ages, there's no risk. Well, that's not true, but just to say that. But what we found, and this is the first time that we hadn't found in the Million Women study, but putting the worldwide data together, we found a persistent risk because we had actually published and said that the risk is only there when people take the hormones, but it's not increased after you stop. And this is the risk that persists, and we've only got information for about 15 years after stopping because that big drop. We don't have too many people who stopped sort of say 20 years ago. But you can see in past years, people have stopped the hormones. This is estrogen, progesterone again, estrogen, again, a linear relationship. The more people took in the past, even if they're ex-users, the greater the risks. And you can see there was nothing they used for less than a year, but increased with duration. So that really, that was very new and really very important when you start thinking about what the absolute risks are. Oh, I also say this was from the Million Women Study published at the same time. Some people argued, who cares about breast cancer nowadays? You can treat breast cancer. It's just, and the breast cancers that arrives in people who take hormones, they're the very benign sort. Don't worry about it. That's another view that's out there in the press, often in the media, not in the scientific. But what we showed from Million Women Study is you look at 20-year mortality from the baseline. Again, you can see that estrogen only, the mortality risks are significantly elevated, more for estrogen plus progesterone than estrogen only, more for more than 5 years of use, and even in past users, there was an increase. So the findings on deaths mirrored the findings on incidence, which again dealt with something that people were often said. So just to say, this is the last slide. This is the sort of worst case scenario, taking estrogen plus daily progesterone, which is worse than intermittent progesterone. If women from age 50 to 70, breast cancer is really common, which is why all of this is important. 6.3% of women who never use menopausal hormones will get breast cancer in the 20 years from 50 to 70. It's a very large number, and that's the problem, a very large risk. So increase it, even by a small amount, you really increase the excess. But it's 8.3% for 5 years use of estrogen plus daily progesterone, which is a 2%, an absolute increase of 2%, which means that 1 in 50 women, and this is just for 5 years of use, 1 in 50 women who use HRT for 5 years, over the next 20, in the next 20 years from when they start, there will be 1 in 50 extra will develop breast cancer. It's someone I was interviewed on the Today program, and Humphreys, who was very polite, very nice, said, that's a, he didn't say substantial, he said that's a, oh no, I forgot the word, doesn't he? Anyway, he was very good, appreciable number, because it's very hard to say 1 in 50 is a large number, a small number. How do you describe it? It's really hard. And he said, and that's an appreciable number. And I said, yes it is. And because it's hard, I said it's hard to say what it is, it's big, small, whatever. And he just melted and was really nice to me the rest of the interview and thanked me afterwards. He came up, as I was walking away, he said, that was really good. So there you go, I just have to. so anyway, but it's 10 years use is 10%, it's a 4% increase, which is 1 in 25 women. And it's really hard to explain to people without sounding alarmist or reassuring. This is the number, and people have to deal with it in some way. That's all I was going to say. Obviously, this work is not my own, all of it, and all these people there behind in the unit have helped in it. So thanks very much, and good luck to the group.
What a wonderful presentation. Thank you so much. For women with BRCA1 and BRCA2 mutation carriers who get their prophylactic treatment at around the age of 35, what would you say about hormone replacement therapy? Because currently people would recommend hormone replacement therapy for these patients.
Maybe no, I'll have to go. I'm going to ask Robert, do you mind going back to one? You know, I showed the slide. No, I don't have to go back. I showed the slide showing that women, even if you start in your 40s, the risks are the same, the relative risks are the same as if you start in your 50s. You have to do, it took us a year, and it was really a year, to work out how to adjust properly for age at menopause. Age at menopause is such an important confounding factor, and it affects breast cancer risk, and it determines when people start HRT use. It did take us a year to work out how to do it. And then when we did it, we could show it's the same. The studies of BRCA1 and 2 carriers don't allow for age at menopause properly. And that is a real serious problem. We have got data which we published in this showing that if you have a family history of breast cancer, the relative risks are just the same. It's not BRCA, we didn't have BRCA1 and 2. But I know people say that there's so many myths going around and so much pressure. I'm not saying, I want to be clear, if people have got bad menopausal symptoms and are really suffering, I'm definitely not saying don't take HRT, but I'm saying bear these risks in mind and don't tell people, as a lot of organizations do, they say it's safe. People use the word it's safe, or you can take it for 5 years and there's no harm. So there are lots of things like that. And I must say, the only thing that but a lot of the people with the BRCA mutations have had bilateral mastectomies. So then that's a different category, but they don't often separate them. It's not great research, I will say, on BRCA mutation carriers.
Can I ask you a question about impact of your research? And let me draw an analogy. When there are media scares about contraceptives, there are really good data on the number of unwanted pregnancies that arise. So do you have quantitative data about HRT use after Lancet publications?
Well, I showed you the one after the trial in the 2000. Now, sir, I'm going to say to you, because I'm asked this often, stopping HRT does not make you pregnant. Of course there's a worry with the pill, and people say that to me often. I'm sorry to pick on you, but really, really, I think this analogy is another question that people say, oh, but you know, remember the pill. Well, look, I've done a lot of work on the pill, and I'm aware of the benefits. There's a clear benefit of the pill. And so, but you cannot say the same, it's not the same, and that's a public health concern if people stop taking the pill and get pregnant. But it's not a public health concern.
I'm just interested in the
Sorry to
impact.
pick on you.
No, Val, I don't mind. It's whether a publication like this actually has an effect on HRT uptake.
Well, we'll see. I don't know, because it was only published a few weeks ago. But we we have been monitoring prescriptions for HRT, and all this drip, drip, drip over the last few years saying, it's okay, it's safe, don't worry, the trials were wrong, this is, you know, it's safe. There has been a little drift up in prescriptions at the moment. and we'll just have to see what happens. But there's you know, that's what's happening. But we'll watch it. But
So-
it'll take a few years to know.
Just one question, and I know Val is going to be here at the afternoon tea, and then she has to go.
Okay,
So
that's
if you
right.
don't get your questions
That's
in,
right.
you'll have a chance at the afternoon tea time. Thank you.
Thank you very much. Thank you very much for the talk. As you explained, there's basically opposing effects when you look at the effect on endometrial cancer compared to
Yes.
breast cancer.
Yeah.
I was wondering, when you look at overall mortality, what the figures look like, for
Yes.
instance, for this graph.
We should do that. This is all. Yes, that's a good question. And endometrial cancer mortality is much lower than breast cancer mortality. The relative risks are higher. It's not clear. The trouble is, in the meta-analysis didn't have mortality data, and we don't have the only study we have mortality data is in the Million Women study. But very few people in this country who use estrogen only have a uterus. No, yes. So you can't really tell, because almost all the information we've got is on estrogen, progesterone, and use, and so it's not very good. But we'll do it someday.
Great. Thank you.
Only
I'm
women.
going to
Only
put a halt to the questions. I'm sorry about that. We're trying to get as many people saying as many things today. So thank you very much, Professor Beryl. Fantastic. So could I ask the speakers in the first session, Jane, Stella, Manisha, Sona? No, I just want Jane, Stella and Manisha up to start with. So our first session now is focused on examples, some examples of research that has been undertaken across the university on pregnancy, gynecological health, fertility and sex differences in non-communicable diseases. And the first session that we have, you're going to sit at their side there, are you, Stella and Manisha? I might get you both to come up. Yeah, maybe if you sit down on there, because otherwise you won't be able to see either, so why don't you sit down there? Yeah, we'll do it back there. So it's my pleasure to welcome Jane Hurst from the Nuffield Department of Women's and Reproductive Health in the first of these 3 sessions focusing on pregnancy. Jane. And I should say I'm going to do 5 minutes on here, so we do stick to time.
Thank you, Robin, and it's a pleasure to be here this afternoon representing the group working on this project, Smart Health Pregnancy. As Robin says, a joint project between the George Institute for Global Health and the Nuffield Department. So, first of all, what is the problem that we're trying to address? And Stephen alluded to the fact that women now die around the world more from cardiovascular diseases, such as strokes and heart attacks, than they do from my area of specialty, which is obstetrics. But what we do know is that there are some women during their pregnancy who develop conditions which put them at greatly increased risk of developing those cardiovascular diseases within the years following the birth. And those conditions are, of course, gestational diabetes mellitus and the hypertensive disorders of pregnancy, which include preeclampsia, gestational hypertension, in them there. So really the question that a lot of us are asking now who are working in maternal health or in epidemiology or in cardiovascular medicine is, can we use pregnancy as an opportunity to improve women's health? So we know the associations there, but can we break that association, and is there some way we can do that? So what our group are doing is we've worked with a group in the George Institute who've developed this innovation called Smart Health, and what it relies on is really a very low-cost method of improving the primary prevention, screening, and evidence-based management of common cardiovascular risk factors, namely hypertension, diabetes. There's also modules for mental health and other diseases. And it focuses around 3 main core principles. Firstly, it's designed with users and the people it's to be with, so in communities. So we're looking in rural India, and there's been a lot of work going on with communities there. It's all components are based on best available evidence. So we are using guidelines for what we diagnose and treat women who develop diabetes or hypertension based on local and international guidelines. And finally, it's developed in a model which is affordable and scalable to the community in which it's offered. And so our approach, the Smart Health Pregnancy Project, and here I must acknowledge very much Dr. Shobi Nagaraj, who's in the audience here this afternoon, there she is over there, who's been leading our work in India on the ground here with the qualitative research and developing the early trial. But we're basing it around 4 real areas of activity. Firstly, working on the ground to identify local priorities, looking at high-risk pregnancy. What does it mean to them? How do they treat it? What happens to these women after the pregnancy? Secondly, adapting and developing the Smart Health intervention specifically for this group of younger women. The current Smart Health intervention is really aimed mostly at older adults, and of course when you're in your 20s or 30s, the risk factors you have are going to be slightly different, and also your priorities. Thirdly, to engage high-level stakeholders, because one thing about all these interventions, and particularly M-Health interventions, is they suffer a bit from pilotitis, where very well-meaning people like myself and others here, we develop a lovely thing, we do a little project, we get a publication, and then it dies. We don't want that to happen here. We want to work with the people who will fund this and sustain this going forward to make a viable business case. So we're having high-level meetings there. We've had some this year already. And finally, we're going to move towards establishing an evidence base in this area so we can say we know how to break that cycle, because currently nowhere in the world we have that evidence. We think with the opportunities we have through the George Institute, we have a chance to try and prove something can make a difference to women's lives, and we're at the moment working towards a large-scale definitive cluster trial. So, of course, this is a very big team effort, and you can see some of the members of the team here and some are in the photograph here, but there are many more people working on the ground in India trying to get this work going. So, thank you.
Thanks, Jane. You had a minute left to go. You've done incredibly well catching up. You've set the standard. So, Stella, let me welcome...
You're going to use the minute.
Because of the pronunciation. Of course. So, I'd like to welcome Stella is a visiting professor in the Faculty of Philosophy, giving a different perspective to pregnancy and birth. Stella.
Thank you. Thank you very much for inviting me. So my contribution, shall I just give it myself? Good, thank you. My contribution is from philosophy. I do philosophy of birth. That is, I use the tools of philosophy to think of the layers of meaning that permeate our practices around childbirth. And the project at the moment is a Marie Curie Fellowship. I need to mention that. Around the world, women are demanding more freedom with respect to childbirth, from less medicalized care in childbirth to elective cesareans for non-medical reasons. At the heart of international and national documents is the need for a call to arms for women-centered care and shared decision-making, not only in order to improve the experience of in women's health services, but also to improve their safety as patients or as users. However, this process of change has reached a certain impasse because it operates under a medical model that does not pay attention to how women view rationality, autonomy, and agency in childbirth. Insofar as these notions are central to what counts as being human, the debate is of profound philosophical import. My approach to philosophy of birth seeks to break down the silos that have existed historically between women's health and philosophical thinking. And I would like to contribute the tools of philosophy to the gender agenda of healthcare equality. Philosophy has not always contributed to gender equality, so it's about time that it does. Today I would like to present only one approach, one example, unveiling the stereotype, capacity and autonomy during labor, or should I maybe pronounce it as a question? Capacity and autonomy during labor? Within maternity care, there is a fundamental problem, which is that while everybody is clear that choice, women's autonomy and freedom and agency are fundamental in theory and in the law, in practice this is often, if not regularly, not enacted. Women's experience speaks to an uncomfortable truth, namely that autonomy in decision-making about their body and health during labor is far from commonplace. The UN report, the Special Rapporteur on violence against women and abuses during facility-based childbirth, that is going to be presented in October in the General Assembly, the UN General Assembly in New York, speaks or gives data about it. I'm interested in exploring what the tension between the law and the practice exactly lies on. Of course, we can always mention time, money, service, pressures as reasons, and they sure play their part. But philosophy can help us acknowledge that the obstacles to enhance capacity and autonomy during labor lie also at yet another layer that is not structural but conceptual, for it has to do with our notions of what capacity and autonomy are. Because I close it. Wonderful. Consciously or unconsciously, professionals do not always engage in true shared decision-making with women during labor because they take them to be obviously not in full capacity. And why are women obviously not in full capacity when in labor? Huh? When are women in labor? The answer is not given in the open, but is something as the following. Because women's lack of capacity during labor is presented as a de facto conclusion of their going through the pain and fear associated to contractions. Their being in an altered state of consciousness is taken to deeply affect their capacity to retain and recall information and balance it in coming to a decision, which is what rationality or reasoning is about. Hence, what they say is taken to not necessarily convey what they mean, nor what they need, nor what is good for them or their babies. In short, women subject to the uterine influence do not reason well. Or perhaps, this is the practice, sorry, I didn't. So how can she fully engage in consent? Or perhaps, am I being provocative? When a uterus enters the door, reason goes out the window. This, I believe, is a crucial barrier to implement consent and shared decision-making during labor. The tension between the full capacity, entitlement, and autonomy that are needed for consent to take place, on the one hand, and the vulnerability, pain, stress, you name it, anxiety, tiredness, that often characterize women in labor on the other. When we take it as obvious that women in labor are not in full capacity, we normalize such judgment, and the normalization leads us to not needing to listen to what they say, nor allow them the space and time to say it. How have we arrived at this position? Stereotypes can play themselves out in the unconscious bias that we all share concerning women in labor as irrational. It takes awareness to challenge those narratives, and philosophy can play a role in uncovering such assumptions. So I examine theories of female rationality and apply them to our approach to women in labor. Look, I am disappointed to say that my fellow philosophers throughout history have underestimated women's rationality and capacity to reason. Philosophy has conveyed ideals of reason that do not fit women to the extent of equating the full exercise of reason as masculine and portraying women as committed to irrationalism. This politically problematic history reflected and contributed to systems of injustice. What now needs to be addressed is the impact of these historical narratives, for their impact goes beyond the internal queries of a discipline, and these stereotypes are observed in our topic, rationality in the maternity world. We need to assess whether traditional associations of rationality with masculinity have influenced the selection of situations and practices of reasoning that were thought to best exemplify rationality. remember that reducing the range of reasoning capacities that count as rational was historically required to readily claim that some people had distinctly more rationality than others. It's only one more paragraph. This can be clearly seen in our area of study, capacity during labor. A woman in labor is considered far from meeting the usual characterization of an ideal rational agent. As such, she is too easily taken in practice, not by the law, this is very important, as unable to engage in shared decision-making processes that lead to consent, sometimes, no? Often, regularly, who knows, depending on the approach. But rationality is more than simply weighing up market prices to know which commodity you need to place your money on. The woman who is screaming in labor that she wants to get up and move is rational too, for she is reasoning towards ends and evaluating resources at her disposal within a situation. For those who are familiar with women's history and the feminist ideas that help illuminate it, there are too many covertly active associations in the discourses and practices around childbirth not to be noticed. From this perspective, the debate on the rationality of women in the labor room is a pressing battlefield, I believe, in which women's entitlement to full citizenship is at stake. And that would be a kind of contribution to what we are all here looking for. Thank you.
Many thanks, Stella. And Manisha is in the Nuffield Department of Population Health and in particular the National Perinatal Epidemiology Unit. Manisha, thank you.
Thank you, Robin. Good afternoon. I'm going to talk to you about MATRI. So this is an international collaborative platform for maternal and perinatal health research in India. Before I go into the structure and the functions of this platform, I'd just like to put a few figures in the context of why we've set up MATRI. There are about 45,000 maternal deaths in India every year, compared to about 70 in the UK. And in some states, like the northeastern state of Assam, there are 6 women who die every day as a result of pregnancy and childbirth complications. Not just that, there are about 5 million pregnant women who suffer a severe life-threatening complication every year in India. So MATRI, a collaborative platform, has been set up to conduct large-scale epidemiological studies in India to understand the causes of these deaths and complications, and thereby to improve maternal and perinatal health. So this collaboration includes hospitals, 14 hospitals across 4 states in India. Most of these hospitals, about 10, are in the state of Assam, and it covers the entire geographical area of Assam. There is another hospital in the northeastern state of Meghalaya. There's one hospital in Uttar Pradesh and 2 other hospitals in the state of Maharashtra. Briefly, this is the structure of the platform. As I mentioned, there are 14 hospitals. 8 are government medical colleges, 3 are government district hospitals, and 3 are private hospitals. Each hospital has a collaborating obstetrician, who is the lead obstetrician, and there are research nurses employed from the project, 1 or 2 based on the caseload in each hospital. The data collection and storage is by using a cloud solution, that is Microsoft Azure. And all these 14 hospitals are managed by a project office set up in Guwahati in Assam. And it has a project manager and an office assistant. We have an independent data safety and monitoring board, which looks after the safety of data and also looks at patient confidentiality and other issues related to it. There is also a MATRI steering committee, which guides the platform and helps us decide priorities for research that are going to have an impact locally in India. And the committee is also entrusted with the responsibility of communicating results and updates to the Ministry of Health and Family Welfare in India. There are 4 strengths of this platform, and the first and an important one for us is standardization. We've standardized this platform in terms of not only data collection, but also in terms of laboratory parameters. A slightly clumsy map shows the network of the blood collection centers that we have within and across the states, from which blood samples are shipped to our national reference lab in our partner laboratory at New Delhi. Equitable partnership is clearly important for long-term sustainability of this platform. So our collaboration agreements with all the institutions in India are based on equitable sharing of intellectual property, equitable co-authorships, as well as data sharing and other things, so that we have a good understanding and a long-term relationship. Capacity building is integral to the platform. So we not only do research, but we have conducted trainings since we've started this program in 2017, and these trainings are to improve skills, research skills, as well as clinical skills in the collaborating hospitals. And the most important that summarizes everything is that this is built to co-create knowledge. That is, we believe in partnership, which so that develops from the ground upwards. Last but not least, I'd just like to show you the research that we are currently undertaking through this. So the first 4 projects are funded by my fellowship from the MRC. And the 5th one is a project that has been just started by a postdoctoral fellow using the platform. There is more information about MATRI on our website. We publish quarterly newsletters, and which you can find on the website. So thank you very much.
Fantastic, thank you very much. Let's just let it go again. Could the 3 of you come up to the stage? Sorry, Sona, we'll see if there's some question. Yes, we're previewing the next presentation. But the 3 of you, if you could come up, and we do have some time for questions to each of you. There's a roving mic up the front and also a roving mic at the back. So questions or comments to any of our speakers?
Jane, could you describe very quickly the smart health intervention that you were talking about?
Sure, thanks, Saris. This is on, I take it. So the smart health intervention is really something that's aimed, as I say, at the community level to strengthen the linkage between primary. This one's a bit buzzy, isn't it? So maybe I'm quite loud, so I'll just talk about it.
No, we close this. We turn off this one and you turn on that one. No, you turn on.
Anyway, I think I'll be loud enough. I'm quite loud. It's designed to strengthen the links between community health workers and primary care doctors at the sort of village level. So what we're doing through sort of the task sharing, I guess, or task shifting, is getting the community health workers to perform the basic primary prevention, screening and referral levels in women's homes, and that's using a tablet app which helps them to do not only to record things like blood pressure or hemoglobin or blood glucose level, but enters into a clinical decision support algorithm which is very clear and tells people whether they're high risk or low risk and whether they need to be referred. And then once those women do trigger that they need to be referred, automatically a referral is sent to their primary care doctor, and he or she will also have an app which will tell them what the national or local guidelines are to treat that condition. For example, if they have hypertension, what should be the first line agent, or if they have diabetes. So it's a whole sort of, it's quite a complex intervention covering a whole range of things in the system. It's also potentially adaptable and flexible to local priorities as well. So it's been used in tuberculosis and HIV and other things when you have, they're the priorities for those areas, but we're looking particularly at hypertension and diabetes.
Right.
I think there's a question.
We have a question.
And there's resistance from different professionals at different levels for these initiatives? And have you found resistance, or has it been well accepted?
It's a really good question, and actually the George Institute have been working for, I think, over 10 years with community health workers, and there's a whole program of work with the George looking from the community health workers' perspective themselves, because these workers are incentivized payments, so they're not on a regular salary, they just get paid for a few hours a day or a week that they do. And so thinking of how does a new thing that we're asking them to do, how does it impact on the other things they're being asked to do, is a really important part of the piece of work, and is being evaluated as part of the work that Shobi's doing at the moment, but also part of the bigger picture going forward. So it's a good question, and something we're conscious of. I can't give you a definite answer, but we're working with communities to try and make sure it's sustainable and acceptable.
Any last questions? Obviously, one more question over here.
Hi, thank you. My question's for Stella. I thought that was really, really interesting, and I guess I can kind of see links between these tensions in the labour room and like hysteria and how women are described that have PMS. And I'm just wondering, once you kind of determine the language that is used around women in the labour room and how that can affect their decision, or whether they're involved in decision-making processes, what kind of tools philosophy can bring to then solve that, I guess?
I think philosophy helps us be aware, and that is already a solution. So once one understands what is going on, of course, one can avoid putting it into practice, but that is then something one does. There is some other thing that can happen, which is that then it's not such a huge step for change to happen. I know this sounds maybe shocking, but it's really, really what happens when one understands that something is going on, that immediately one finds ways to say things differently, because we all have the skills, the linguistic skills, and the reason, the capacity to engage with others, understand what is going on, and behave towards the others. We don't need to learn that. We are human beings. And most of us don't need to learn that. So, of course, there are many things that can then happen, and we have to do for them to happen. But the trickiest part is done.
Great. I am going to draw this to a close. Thanks, Stella, Manisha, and Jane. Please talk to them at the break. If I can, Sona, do come up now. Thank you. So we're moving now into our second session, which is on sex differences. Thanks. And Sona's from the George Institute and the Nuffield Department of Women's and Reproductive Health.
Thanks, Robin, and thanks everyone for being here today. It's really great to have such a big crowd today. So I'm indeed going to talk about, I'm going to move away from women only, and I'm going to focus on sex differences here. And, well, Stephen was preempted some of my talk, but just to re-emphasize, why are we doing this kind of stuff? Well, like Stephen said, a couple of years ago, I think in 2016, we launched this policy paper sort of addressing not only the importance of taking a life course perspective towards women's health, but also to re-emphasize the importance of looking at sex differences, not only where you think that sex differences exist, but sort of across the board in order to identify differences where we didn't expect them initially. Well, historically, most of the work that has been done on communicable diseases focused on male populations predominantly. And, well, the reason behind it, it was anyway to protect, in order to protect women, because we thought that we considered women to be, in a way, we considered them to be, I don't know, not really weaker, but I mean, there's a lot of issues around pregnancy, of course, that might be dangerous for both the mom and the child. So we thought that if we do studies in male, then we can just translate it to women, and we're all fine. However, over the past couple of decades, I would say, it's increasingly being shown that this is not the case. And in our policy paper, we've outlined this, and we've shown that, we argue that we should undertake the sex aggregated analysis at any kind of stage in the medical cycle, and indeed not only medical cycle, but also in other disciplines. And of course, in order to be able to do this, we need to include enough women in studies, and we need studies like the Million Women Study to focus on issues that are exclusively relevant to women. So in the next couple of slides, I'm just going to give a couple of examples of where sex differences research is relevant. And this is data not from Oxford, this is from the Netherlands actually, from the Rotterdam study, where they looked at sex differences in the presentation of cardiovascular disease. Because as Stephen said, cardiovascular disease, in addition to other non-communicable diseases, is indeed one of the leading causes of death among women worldwide. But if we stop there, we sort of like forget about very important differences in the presentation of cardiovascular disease. And what this slide demonstrates is that, yes, indeed, the lifetime risk of cardiovascular disease is similar between the sexes. But there's, first of all, if you like, a difference in the age of first onset of cardiovascular disease of about 5 to 10 years. Women tend to get it 5 to 10 years later than men. And also the type of cardiovascular disease women and men suffer from is different. So as this slide illustrates, on the top panel we have men, and we see that from the age of 55, the rates of coronary heart disease increase steadily, whereas in women, from the age of 60 onwards, it's primarily cardiovascular disease or stroke that dominates among women. So this is one reason to look at sex differences. This is an example of our own work, where we looked at sex differences in the prescription of high-intensity statins among people who are using statins and among people who had a history of myocardial infarction. And the clinical guidelines at present say, they just say that everyone with a history of myocardial infarction should get a statin, and they should also get a high-intensity statin. So what we did in this piece of work, we just looked at, first of all, the trends in the use of high-intensity statins, both in women and men. And as you can see on the slides, in 2011, new guidelines were released in the United States in 2011, and from that point onwards, there was an increase in the use of high-intensity statins. And this slide is stratified as to whether these people used statins prior to their first MI, but we saw an increase. But what didn't change, where we didn't see any difference, and that's, I think, most strikingly, is that despite these changing guidelines and despite the increasing recognition of awareness of the importance of sex differences and the importance of cardiovascular disease in women, there continues to be about a 10% gap in the use of high-intensity statins among statin users in women as compared with men. So yeah, it's just there, and we need, of course, to do something about it. This is a piece that I took out of the Oxford Martin School policy paper, where we looked at sex differences in risk factor disease associations. So what this slide demonstrates is that in the columns you see that each of the common risk factors for both heart disease and stroke indeed increase the risk of these conditions in both women and men. So we looked at it, we pulled together all the evidence that was available at that date, so approximately 5 years ago, I think already, for high blood pressure, smoking, and type 1 and type 2 diabetes. And like I said, each of these risk factors increases the risk of heart disease and stroke in women and in men. But some risk factors, and primarily type 1 and type 2 diabetes, seem to increase the risk of heart disease and stroke more in women than men. And at present, we're trying to find out why there is an excess relative risk in women as compared with men for some, but not all risk factors. And this is my final slide, where I would like to present one potential reason why these sex differences exist. And for diabetes, it may be because there's differences in women and men. There's differences between women and men in body fat distribution and body shape. And on this slide, I show that women at the point they get diagnosed with diabetes, they tend to have a higher BMI as compared with men at the point of diagnosis. And these differences in body fat distribution may explain why diabetes is a stronger risk factor in women as compared with men. I'm sure my next speaker will say a little bit more about that, but I would like to to finish with this. We just need to disaggregate the data in order to, to study women's and men's health. Thank you.
Thanks, Sonna, and I'd like to welcome Professor Cecilia Lindgren, who's part of the Big Data Institute and the Nuffield Department of Women's and Reproductive Health. Thank you, Cecilia.
I'm one of the newest members of Nuffield Departments of Women and Reproductive Health, and very proudly so I'm excited to be here today. So I'm going to tack on to what Sanne was talking about and take you into the world of genetics. So obesity, as Hanne was alluding to, is a major contributor to most, if not all, non-communicable diseases on the WHO top 10 killer list. It's a multifaceted, heterogeneous condition with no current efficient treatment. And when you say this, especially to a room of clinicians, they usually start to get heart palpitations and find it unpalatable, because we all know that if you eat less and exercise more, you will lose weight. However, it's not as trivial as it might seem, because we're currently in an obesity epidemic, even if that's also an unpalatable thought, with about 65% of adults in the UK today being overweight, and about 24% of those are obese. So, I mean, it's a serious problem, and it's not normal to be normal weight anymore. And if the solution was that simple, we would all look fantastic and be super slim, but that's also not the case, sadly. It's a heritable condition with a clear genetic component, and that's sort of where I come from and what I'm interested in. So when people aggregate fat during weight gain, there are two sort of standardized or sort of schematic sort of ways that this can happen. You start to aggregate fat subcutaneously, and different people have different depot capacity under your skin, and when that's sort of saturated, and that capacity is different, and Stephen O'Rahilly in Cambridge has done excellent work on this, you will start to shunt fat ectopically and abdominally, sort of preferentially visually, and that's when adverse health outcome starts to happen usually. So you can either get into a pear-shaped obesity or a gynoid or a female-shaped obesity where you have increased subcutaneous fat, and that carries low risk of diabetes and metabolic syndrome. Keith Frayne and Freddie Karp has done some wonderful physiology on that. Or you can have an apple-shaped obesity where you have increased visceral fat, a male-shaped obesity, and you're in high risk of diabetes and metabolic syndrome. What most people don't think about is that they have distinct genetic components contributing to fat patterning of the bodies, and this is crucial when we move forward into thinking about why some people get heart attacks as a consequence of obesity or not. So over about the last 20 years or so, since I started my PhD, I've dedicated myself to try to disentangle the genetic underpinnings of a range of metabolic diseases, primarily overall obesity and fat distribution. And this is just the latest version of the data, where we have merged a large-scale genetic consortia, global consortia called the GIANT Consortia, with the UK Biobank data. And we have looked at 28 million genetic variants in about 700,000 individuals informative for BMI. And we find about 346 different loci with 469 signals, genetic variants that are independently associated with fat distribution, and over 700 independent signals for overall obesity, which means that now we have over 1,000 regions in the genome that are associated with a direct sort of direction to obesity. And 2007, we had none of those variants. And that might sound a bit like a fruit salad. It looks like the entire genome is associated, so why are we interested in that? Well, I'm obviously interested in it. One of the key findings that we did 2008 when we started to look at it was that when we started to look at the genetic underpinnings of fat distribution compared to those of overall obesity, we started to see that the effect sizes in women were considerably stronger, significantly stronger than those in men for fat distribution, but that didn't seem to be the case for overall obesity. So this is the latest version, and I want to point out Sarah Pullett down in the corner, an excellent postdoc, has worked with me before. So she has done some of this work. And in the latest data, we see 30% of the significant associations that show a strong, significant signal of sexual dimorphism, where they're stronger, almost all of them are stronger in women than in men, compared to about less than 1% of the loci for overall obesity. So there's a clear distinction between how overall obesity, which is a neuroendocrine condition, and fat distribution, which is a peripheral sort of trait, sort of regulates somehow, and how it presents in men and women is different and has a genetic underpinning. These slides I want to point out, because sometimes when I present them, somebody asks me, like, well, why are you in the Big Data Institute? Represent 40 years of postdoc and PhD student work that has been crammed in to a couple of slides here, just to give a sense of magnitude, because somebody always comes afterwards and says, I want to run a GWAS, can you do it? And I'm like, no. So then I've had the great pleasure of collaborating with Sanne and also Jenny, my PhD student who is here in the audience somewhere, I think, and also Michael Holmes, where we started to think about then, so are there a causal contribution between obesity and the top 10 killers of non-communicable disease? And the answer is yes. In 6 of 10 of the leading non-communicable diseases on this list, we have a significant causative relationship. And in 3 out of those 6, there is a clear sexual dimorphism, where we see that fat distribution increased risk causally of renal failure, type 2 diabetes, renal failure and lung disease, COPD, and body mass index increased risk of type 2 diabetes more in women, which marries what Sanne was saying before. And this is really exciting for us because it gives us a sense of that there are different pathways underlying. So some of you might say, well, it's not all disorders. I want to point out that we have just started to scratch on the surface here. We have not looked at age of onset, which might carry different underlying genetic causes and mechanisms. And we haven't looked at severity of disease, duration of disease, and all kinds of phenotypes. So the topography of the entire phenotypic landscape is something that we're thinking about dissecting further. But there's clear causative evidence and clear sexual dimorphism in the underlying causes, which we think will have downstream implications for public health and how we think about these diseases and how they're treated. So I'm just going to say thank you, and then I'm going to pass over to the next speaker, I think, Robin. So I missed a minute for someone.
Cecilia and Sonna, can I get you both to move up just for a short time to see if we've got any burning questions or comments from others in the room? Lou, we've got somebody down the front here who wants to ask a question.
To Cecilia, thank you for that wonderful talk. So in terms of obesity and fat distribution, ethnicity is quite a powerful factor here. Does the ethnicity change the effects that you see with sexual dimorphism?
That's a really good question. So shame on us that 90% of the current genetic studies are done in Northern European ancestry samples. I'm not able to answer that, though I will proudly say that I'm a founding member and co-chair of the International Disease Consortium, or Alliance, we should call ourselves. And one of the key sort of aims we have is to get a wider, more global representation of GWAS data. And I know that there are some people here from the China Kidori Biobank and maybe also from the Mexican Biobank and so forth. So there are large-scale efforts undergoing, but I will say that we won't be able to answer it in a large-scale, robust way at the moment, but that's not something I'm proud of.
Question at the back, Lucy.
Hi there, thank you. This has been fascinating. I wanted to ask about your really pertinent question about can we always disaggregate for sex differences? And I actually wanted to ask about some of the technical ways you might advise doing this, because what you often see is that in, say, a survey or a randomized trial, gender or sex is introduced as a moderator, a potential moderator. And you made the point that if the sample size is not large enough, what you end up with is a null result, possibly because you're underpowered. And I just wondered if you had any advice for researchers who may not have 1 million people in their data set, but may have 1,000 or 5,000, and what we might be able to do to improve that.
Yeah, well, that's an excellent question. I mean, the results I showed for the sex differences in the risk factor associations with disease outcomes are actually based on meta-analysis where a lot of studies and often like hundreds of cohorts, the results from hundreds of cohorts were pulled together. So as you allude to, a lot of smaller studies may not be able to provide conclusive answers, but if we meta-analysis amongst us, if we're able to pick those sex disaggregated analysis from the individual publications, we are able to come to more definite and more conclusive answers. So I think sex aggregation, even if it's not, if you find null findings in your own study, well, it definitely suits the purpose.
I just want to add on that I sit on the NIH Sex Difference Task Force, and one of the proposals they put forward to NIH is not to fund any studies that aren't well powered enough to address this question because it's crucial to fold in. So we should all aim to collaborate with or do studies similar to the Women's Health Study where we're well powered. So it's provocative.
Val, last question from Val before we move to the last
Thanks very much
session.
about your presentation on risk factors for disease or sex differences. You've got to bear in mind that women have different exposures to men. And I mean, the example of smoking, I think, is the best one because women, until the recent generations, when I say that, generations post-war, smoked less than men. And the paper, which was on another million people but from the US, on the American Cancer Society, showed that over time, as women approached the same smoking rates as men, the absolute risks were just the same in women as men. So I think one of the problems about sex differences is you've got to be sure, in risk factors, you've got to be sure that you're talking about the same exposures at the same time, and mostly one's not.
No, absolutely, and in our paper on stroke, we were able to disaggregate the analysis by region, where we split out the Asian versus the non-Asian studies to address that point of the maturity of the smoking epidemic. Because if you're right, I mean, if you look at the more recent studies, the excess risk of smoking in women is actually even larger than when you look in the smaller studies. And I think the Million Women study also had a publication on that a couple of years ago in the Lancet, I believe, on the full hazard of the smoking epidemic in women. Thank you.
Great, thanks. Well, thank you very much, both of you. And if we can move to the next speaker. And this last session within this session is a focus on gynecological health and fertility. And our first speaker is Professor Krina Zondervan from the Wellcome Trust Centre for Human Genetics and Nuffield Department of Women's and Reproductive Health. Krina, thank you.
Thank you very much. So the challenge to me to give you 5 minutes of endometriosis, tell you a bit about what it is and what we're doing in terms of genetics and genomics to help improve the care of women globally. Don't know how many of you have heard of endometriosis. I think there's an increased awareness of endometriosis. Should I lift it up? Yeah. It's my height. I'll have to aim higher. Endometriosis is a chronic inflammatory condition where you find endometrial-like tissue in the pelvis, so outside of the uterus. And endometrium is the lining of the uterus, is the tissue that responds to the hormonal fluctuations, obviously, where the embryo implants, etc. And that's being shed on a monthly basis. Endometriosis is a major cause of pelvic pain and infertility. We mainly see it in women of reproductive age because it's a hormone-dependent condition. It's, the growth is dependent on estrogens. And the main clinical challenge and the challenge women face is twofold. Firstly, the diagnosis really primarily is done through surgery, visualization through laparoscopy, which means that the average diagnostic delay of women with endometriosis from the first time they experience symptoms is about 8 years. And this is a pattern we see globally. A second challenge is that the treatment is really limited to repeated surgeries to remove these lesions and hormonal treatments with many side effects. Endometriosis is a very under-recognized public health condition, and these are statistics that always surprise people when I show them. The population prevalence is unknown because of the need for surgery to establish a diagnosis, but estimates from surveys surrounding pelvic pain and infertility and the women that are seen in secondary tertiary care is that it affects an estimated 5% of women of reproductive age to a varying extent. So this equates to about 190 million women worldwide. It very significantly affects quality of life of women and their families, and the economic burden has been estimated to be very similar to that of, for example, type 2 diabetes. Now, about 2 years ago now, The Guardian had an extended coverage feature series on endometriosis. For those of you who are interested, please do go back, all the articles are still there, where they highlighted the extent of the problem. And what they also highlighted was the extent of the problem in terms of funding given to women's health in general, but endometriosis in particular. And that for each person with diabetes in the US, the NIH spends about $36 each year. But for each woman with endometriosis, it's less than $1. Causes for endometriosis are largely unknown, but we've known for a long time that endometriosis is heritable. The heritability, which means the population-based risk attributable to genetic factors, is about 50%. So with genetic studies, what we aim to do is understand the disease better, to find methods, diagnostic methods for non-invasive diagnosis, and to improve treatments. So for a number of years now, we've been working in a consortium setting, the International Endometriosis Genomics Consortium, to amalgamate all studies globally who have genetic data on women and those with diagnosed with endometriosis. So we now have about 61,000 cases altogether. And the eagle-eyed of you will see that, similar to what Cecilia described for a lot of the GWAS studies in obesity, is that these data sets primarily sit in Europe, the US, some in Japan and in Australia. And we have very little data elsewhere. A peek at some of the unpublished results that are relatively hot off the press. So we have, and this is very much behind some of the results that Cecilia described for obesity and also what we know about type 2 diabetes, for example. We now have 44 regions in the genome with significant signals. 32 of those we've just discovered in this consortium setting. And what we're doing as well is we're uncovering the heterogeneity of the disease. So for a number of these data sets, we have very detailed phenotypic and surgically quantified data. And so just to explain the plot here, this is what's called a Manhattan plot. Every single dot is a variant. On the x-axis is literally the genomic position. On the y-axis is the significance of association. And the plots here on the right, you essentially zoom in. So this is an example of a locus where we see a very strong signal for what's called stage 3-4 endometriosis, but we don't see anything at all for stage 1-2. And we have a lot more deep phenotypic data now on these women, and we can start drilling down into these kind of patterns of differential genetic regulation of subtypes of endometriosis, which will directly inform new diagnostic methods, but also much more better targeted treatments. A big question we have, and we can fill a whole hour on this, is how do we go to translation of these results? Because what I showed you on the previous slides is very simple. We annotated all these peaks with the nearest gene that is there. That does not mean to say that that's the gene that's being perturbed by that genetic variant. We need to translate that in tissues that are relevant to the disease, and in this case, that's endometriosis. So we do association studies where we have for specific tissues, we have genotyping results, and all sorts of molecular phenotyping results, including protein levels, and we can assess what a genetic variant does to protein expression. Now, the challenge we have is for endometriosis, we need to do this in endometrium and its constituting cells. And there have been major efforts worldwide in creating atlases to do exactly this kind of work across the human body. But lo and behold, they do not include endometrium. And this is a feature that I think is present for a lot of women's health and reproductive health conditions. So what we've done is we've led an effort globally to try and standardize all the data and samples that are being collected for endometriosis research, which has been a major effort, but also one that's been adopted widely. So we now have 30 adopting centres in 19 countries, and there's another 11 emerging. And as you can see, what we're very much trying to do is encourage global representation in this. Now, the last slide is just to show what we're trying to do in our department. I lead the Endometriosis Care Centre together with Christian Becker. What we're trying to do is integrate all that genomic work in which we collaborate with a huge number of people already within Oxford to the clinical studies that are ongoing, looking at pain aspects and pain sensitivity led by Professor Katie Vincent, and also the tissue and cellular-based studies at a very detailed level. And in all this, we are collaborating with pharma and diagnostic companies to try and ensure that what we find is translated to something that benefits patients and women. Thank you.
Thanks, Karina. And our last speaker is Dr. Lisa Hinton from the Department of Primary Healthcare Sciences. Lisa.
Right, so I'm conscious that I'm between you and a cup of tea and getting to talk to the people in the audience, so I will be brief. I'm going to shift gear a bit now. We've been talking a lot about big data. I'm going to be talking about work that we've been doing in the Health Experiences Research Group in the Department of Primary Care in Oxford, looking at patient experiences. We've been doing this work incrementally over the last 20 years. And I just want to tell you a little bit about the work we've done and some of our findings in relating to infertility in particular, but also just to remind you and tell you a little bit about the resource that's there that could be of use as we take some of this work forward. So firstly, why are we interested in patient experience? We often talk about putting the patient at the centre of all that we do, but actually trying to understand patient experiences and scale up their impact is a relatively new endeavour, and it's now well understood and established that patient experience is absolutely at the heart of quality patient-centred care, along with clinical effectiveness and safety. And there's an example here of a book written by Sue Ziebland, who is the lead of our research group, that pulled together some of the different approaches that we can use to understanding and scaling up this research in health experiences. We in the Health Experiences Group have been working on a number of studies over the last 20 years that have all been published on this public-facing website called Health Talk, which some of you in the room may be familiar with. It's a free-to-access, non-commercial website that has now over 110 different health conditions that are archived on it. You can read about patients' experiences of all the major cancers, major heart diseases, and conditions throughout the life course, from experiences of pregnancy and antenatal screening all the way through to caring for a relative with dementia. There are, in each of those individual studies, there are hundreds of video and audio clips illustrating the extracts and analysis from the research that we've done, which is based on interviewing around 40 to 50 individuals around the UK for every one of those particular health conditions. And we also now have an international collaboration, so there are 13 other countries worldwide who are conducting similar studies and doing country-specific projects. So what is out there in terms of women's health? So it's a resource for public and patients to learn about the health and care experiences of their peers. But it's also a resource that can be used to teach clinicians about patients' perspectives. It's an archive of rigorously collected research that can be used for secondary analysis, and I'm actually collaborating with Sana and others at the George Institute at the moment, looking at some of the data we have on experiences of heart disease and stroke, and particularly looking at the interviews that we did within those samples with women to try and understand if there's anything that we can start to tease out around some of, to understand some of the big data through some of the experiential data. And these studies are also used regularly to inform service improvement and co-design projects based on what matters to people. I've given you here a flavour of the different subjects that we've touched on in specific relation to women's health. So starting in the top left with antenatal screening and breastfeeding, all the way down to the bottom on the right-hand side there, ovarian cancer and menopause. Those are the women-specific modules that we have on the site, but there's also obviously samples of women embedded within almost every other module that we've done, with the exclusion, I think, of prostate cancer and testicular cancer for obvious reasons. So just to bring this back before we have a cup of tea to some of the work that we have done on fertility in particular. So this is work that I conducted about 10 years ago now. I interviewed around the country 38 individuals who had experienced difficulties with getting pregnant and had gone through fertility treatment. I interviewed primarily women, as it's mostly women obviously that have to go through treatment, but there was also a sample of men that I included in those interviews. The module, that's the front page of the module there, where you can read about people's experiences of diagnosis, making choices about decisions, and going through treatment. And we published several papers from that study, and I've given you an example here, which was one that we published that really tried to surface. It was one of the early papers that tried to really understand the use that people were making of the internet and online support to help them cope with the isolation and psychological burden of going through treatment when they were feeling very isolated from their local communities. I think nowadays we have a much richer understanding of the role of online support and social media, but this was certainly something quite innovative when we looked at it at the time, and I am just about to stop, so I think I get the prize for being the most on time. Anyway, I hope that just gives you a very quick flavour of the resource that we have there, but there's an archive that is available to be mined for secondary analysis, and please do come and talk to me if you'd like to find out any more. Thank you.
So, Krina and Lisa, just sit up. We'll just take 2 or 3 minutes before we stop for a short break. Questions, comments to Krina and Lisa? Yes, thank you.
Could I have some thoughts from you, but also from other panels? Where are the treatment options in, say, 10 or 20 or 30 years' time going? I'm struck that when you try to explain, I'm an economist, I'm not a biologist or whatever, but you look at the genetics, as you were describing, highly heterogeneous, and in the one or two of the other panels, it was like, all the potential genetic explanations. It's not like there's one gene, there's lots of things. So from an R&D and a development of new interventions perspective, that's challenging, is it, or is it not? Thinking 10 or 20, 30 years from now.
Yes, it certainly is challenging. I think that's where translational research essentially comes in. So obviously genes are part of a network of interactions that impact on biological pathways. If you speak to pharma, how they look at drug development, they will not necessarily look at individual genes, for example. They will look at pathways and networks, and to what extent an element of that could be intervened with to affect the results of that pathway. So you need to understand, in much more the complex way a variant could impact on disease. That's also one of the reasons why, what we're looking at with genetic variants is very, very small effects. That's often seen as a reason of, well, they're very small effects, so why would you want to focus on that particular gene? I think that misses the point. It's trying to identify the small perturbances that these genetic variants have and put an overall picture together of how that affects biology. In terms of where we're heading in treatments, I think women as well as pharma as well as academia is pretty much in agreement that we need to move away from hormonal treatments. I think there's a real emphasis on trying to interrogate the inflammatory pathways in particular, and perhaps find treatments that impact on that. Maybe also more localized treatments rather than systemic ones. So yeah, but it is a challenge.
Okay.
Any other questions or comments? You were right, Lisa. Afternoon tea is beckoning. So thank you for all of those who've contributed to this first session. If you do have questions or comments that haven't been addressed, please use Mentimeter. We'll take a break now, come back at 3:30. On your labels here is your name and 3 words. That, we hope, will be a conversation starter as you move to have a cup of tea and come back. Thanks very much.